In this lecture, we will be studying burning mouth syndrome, or BMS for short. BMS is a chronic oral pain syndrome that is often very challenging to diagnose and to treat, and though not so common, can be significantly debilitating to the patients having this condition. By the end of the lecture, that is after all the sections and lessons, you should be able to accomplish the following learning goals. Firstly, you should be able to define burning mouth syndrome as outlined by both the International Association for the Study of Pain and the International Headache Society. Instead of memorizing these definitions, it is more important to understand them in the clinical context, since not every patient with BMS will have symptoms that follow these definitions word for word. As a result, I will try to put this into context for better understanding. Our next learning goal is to be able to classify burning mouth syndrome. I will speak about two main groups of BMS, and this will be the more common grouping of primary versus secondary BMS that is often used in the medical and dental literature. We will also learn about peripheral burning mouth syndrome and central burning mouth syndrome, and as we do so, we will find out that the treatment approach for each of these two may actually be entirely different. Our third learning goal will be to understand the mechanism of disease and pathophysiology of burning mouth syndrome, including some current hypotheses. Learning about various factors that may play a role either in isolation or in combination. We will also learn about two related extraoral conditions and how they may influence the management of burning mouth syndrome. Now, just for a start, these two conditions will be the restless leg syndrome and the restless genital syndrome. These two lesions, or these two conditions rather, have similar pathogenesis as burning mouth syndrome. Our fourth learning goal is a very important one, and after the lecture, you should be able to describe the pain characteristics and clinical presentation of patients suffering from burning mouth syndrome. Understanding this will influence very greatly the treatment options, which in fact is our next learning goal. You should be able to provide treatment options for these patients. A great part of the lecture will emphasize various treatment modalities for burning mouth syndrome. There are no treatment guidelines, so we will look only at some successful approaches used and outlined in the literature. I will discuss pharmacotherapy and non-pharmacotherapy, and we will come to appreciate why management is carried out on a case-by-case basis. Finally, to test your understanding of the topic, there will be a quiz available after the last lesson in this lecture. Now, you can be able to retake the quiz just in case you want to improve your scores. So, without wasting much time, grab yourself a cup of coffee and let's start with our first lesson. Burning mouth syndrome is considered a central cause of facial pain by the International Headache Society. What does this mean? Well, simply, central pain as defined by the International Association for the Study of Pain, or IASP, is pain that results from a lesion or dysfunction in the central neural axis. And some types of burning mouth syndromes known as the central BMS will have dysfunctions in the basal ganglia, as you will see when we discuss the pathophysiology section. Now, just to complete the picture, let's mention the other members of the group, that is the central causes of facial pain. It's a 5-member group comprising anesthesia dolorosa, central post-stroke pain, facial pain from multiple sclerosis, persistent idiopathic facial pain, and BMS. Anesthesia dolorosa is when one experiences chronic pain at the site that is supposedly numb. So for instance, this can be a sequelae to destructive surgeries for trigeminal neuralgia, such as following rhizotomies. Central post-stroke pain is pain following a cerebrovascular incident. Multiple sclerosis is a demyelinating disease that leads to facial pain and ophthalmic issues. It can affect the trigeminal system, leading to patterns of trigeminal neuralgia in the individual. PIPF is chronic facial pain that does not follow any of the pattern of cranial nerve neuralgias. So for instance, you would not find the typical pattern as in trigeminal neuralgia or as in glossopharyngeal neuralgia. I'm sure by now you can see the central trend within this 5-member group. Note again that for BMS, it is only the central BMS that will fall under this group. The peripheral Bennett syndrome, which is a result of trigeminal nerve neuropathy, will not fall into this group at all. That being said, any of these could be included in the differential diagnosis of Bennett syndrome. Now, let's look at the classic definitions of Bennett syndrome as given by the International Headache Society and then the IASP. The IHS defines Bennett syndrome as an intraoral burning or dysaesthetic sensation that recurs daily for more than 2 hours per day over more than 3 months without clinically evident causative lesions. Now, I don't know about you, but these timeline definitions are not my favorites. How about modifying it to read as follows? So we have now an intraoral burning sensation recurring daily for most of the day and with normal oral mucosa. Systemic disease is also excluded. Now, we will learn about the pain characteristics of BMS in section 3, but this should give you a head start. When we look at this definition, one thing comes out to be very important, and that is the fact that all these symptoms are going on in the presence of clinically normal or healthy oral mucosa, and without the presence of a systemic disease that will explain the symptoms. This definition is classically given to primary burning mouth syndrome, as opposed to secondary burning mouth syndrome, where there will be some local or systemic reason for the oral burning. From now onwards, anytime I say BMS, assume primary burning mouth syndrome, unless I say otherwise. The most common intraoral location for BMS is the tongue, and for this reason, BMS has also been called glossoptenia, or burning tongue syndrome. Now, this brings us to the next definition by the IASP, the International Association for the Study of Pain. Here is their definition, and they've added some important information. First of all, we see that they say the pain is often bilateral. So, example, the right and the left sides of the tongue or the tip of the tongue in the midline. Also, they stated that there's abnormal taste sensations or dysgeusia and dry mouth, which is often subjective. About 2/3 of BMS patients will have the feeling of dysgeusia and or dry mouth, even though objective testing may not reveal anything significant. Now, let's have a pop quiz. Which of the following are considered synonyms of BMS? Well, here are your options: stomatodynia, glossodynia, glossopyrosis, idiopathic orofacial pain, and stomatopyrosis. Think about this for a bit. You can pause the video, but the answer is that all of them are synonyms of glossodynia. Stomatodynia means painful mouth. Glossodynia means painful tongue. Glossopyrosis, well, first of all, pyrosis in of itself means heartburn, but then glossopyrosis will mean burning tongue, and then stomatopyrosis will also mean burning mouth. Idiopathic orofacial pain is self-explanatory, meaning unknown cause of orofacial pain. Now, other terms that you may come across in the literature are essential burning mouth syndrome and idiopathic burning mouth syndrome. They are all synonyms for primary burning mouth syndrome. Essential idiopathic meaning we do not know the cause for the condition, but then the pathophysiological mechanisms are still being unraveled. That being said, there is no cure for BMS, and a better understanding of the pathophysiology will help improve treatment outcomes for these patients. Our current treatment modalities may really only be effective in about 30% of cases, and it is very important not to raise the patient expectations unnecessarily. Current treatment approaches will often include drug therapy and psychological assistance, since psychiatric illness and psychiatric stress has been thought to play a role in the pathogenesis of BMS. The big players here will be major depression and anxiety, amongst other psychiatric illnesses, and they have a strong association with BMS, and as a result, anxiolytics and antidepressants can be very effective therapeutic agents in relieving symptoms of burning mouth syndrome. Now, there is a complex interplay between psychiatric stress and the severity of chronic pain, such as BMS, and this figure summarizes this pretty well. Basically, the more severe the pain and the longer it lasts, the greater the psychological stress and the worsening of anxiety and depression, which may in turn exacerbate the perception and experience of chronic pain, such as BMS. As a result, some of the current range of therapies available involve both topical and systemic pharmacologic agents that have psychotropic properties. Now, here is just an overview, and we will delve more into this list of drugs, talking about the mechanism of action and the dosages of these agents in section 4. We will also explore some additional and relatively newer agents that may be used in the management of symptoms of BMS. For the topical agents, we have clonazepam, which in fact can be used both topically and systemically. We also have lidocaine, which often is used as a local patch and can be useful in the peripheral type of burning mouth syndrome. Also in the list is capsaicin and doxepin cream. Now, there's a single combination preparation of capsaicin and doxepin that actually proves very effective in various chronic neuropathic pain conditions. 2% amitriptyline can also be used as topical agents, but then we most of the time prefer the systemic use of amitriptyline. Now, the list of systemic agents involve benzodiazepines like clonazepam, which can be used systemically as well, tricyclic antidepressants like amitriptyline, which in fact is the most effective TCA for primary BMS. Also in the list is alpha lipoic acid, which has neuroprotective properties and is an antioxidant. Anticonvulsants such as gabapentin, either used alone or in combination with other agents. Some serotonin reuptake inhibitors and serotonin norepinephrine reuptake inhibitors can also be very useful. Finally, on the list are opioids, which are very rarely used in the management of BMS patients. In medicine, when you have a broad range of drugs to treat a condition, it often means that the pathogenesis of that condition is obscure, and burning mouth syndrome is not an exception. Now, there are non-pharmacologic therapies that are often used in recalcitrant cases or in patients with significant psychiatric distress. CBT or cognitive behavioral therapy will be one of the approaches for this group of patients. And in some cases, when everything fails, electroconvulsive therapy is often employed. Now, let me say that there are currently no treatment guidelines for burning mouth syndrome, and these therapies are only based on successful usage in various clinical scenarios within the scientific literature. Management should therefore be carried out on a case-by-case basis. Before moving on to the next lesson, let's quickly review some terminologies that will prove useful in subsequent discussions on the topic. First, let's talk about pain. Now, most people think of pain as a stimulus. For instance, a painful nail injury, a painful pinprick, or touching a hot stove or something similar. This noxious stimuli sends information which are sensory to the primary somatosensory brain areas in order to be perceived as pain. Now, it does not end there. This information is also then relayed to other brain areas such as the limbic system, which is responsible for emotions and behaviors. Therefore, in a nutshell, we can say that the stimulus in of itself is not really pain. Now, if I turn around and I transect the axon, the noxious information can never reach the brain and hence there will be no pain. So pain is more than just a stimulus, okay? Pain is an experience. Pain is a perception of the brain. It has both emotional and cognitive components, and as a result, the experience varies from person to person. Now, the amount of pain a person feels will depend on the context in which he or she experiences the pain. A good example will be when you feel almost no pain in fight or flight situations, such as when you are being chased by a wild animal or when you're fully involved in a sporting activity. This interindividual variability becomes very important in guiding analgesic therapy for our patients, and it becomes very necessary to personalize the treatment so you do not under-medicate any patient. Under-medication is not only bad for the patient, but also has legal consequences. And if you think a patient may be malingering, it is best to refer or get advice from another professional. Now, to reiterate some of the points I said earlier on, let's look at this scenario. Let's say Stephanie and James went out to pick flowers in the park. Unfortunately, they both had a thorn prick from one of the plants they picked. This will be the stimulus and not yet the pain. Take note. This stimulus gets transduced to the central nervous system to be perceived as pain. But because of the emotional and cognitive aspects that we talked about earlier on, they both may not experience the same level of pain impulse, and therefore each will require a different treatment approach for their pain alleviation. So in this case, James may need a more aggressive intervention than Stephanie. Let's put all this together by looking at the standard pain definition as given by the IASP. It says pain is an unpleasant sensory and emotional experience. Nothing new here, we've talked about this at length. Now, this experience can be associated with actual or potential tissue injury or described in terms of such damage. Now, very often when there is pain, we expect to see tissue injury, and for the most part, this is the case. And then in some cases, such as neuropathic pain disorders like BMS, there may not be evidence of injury, and these patients will only describe their pain in terms of such damage. It is therefore important that you believe anyone that says they have pain. Now, just to reiterate this further, pain is whatever the experiencing person says it is, and existing when he or she says it does. You must always acknowledge that pain is only a sensory information that is modified by both our emotions and cognition. Now that you have an idea what pain is, let's quickly run through some pain terminologies. Hyperalgesia is when there is increased sensitivity to pain. That is to say, it is a state of nociceptive hypersensitization. So for instance, a minor insult like a needle prick, for instance, on the finger becomes as though your whole finger was scratched and feels 10 times worse. Hyperalgesia can be a symptom of BMS. Flipping things around, when there is pain response to an innocuous stimuli, we refer to this as allodynia. Allodynia can also be a BMS feature, but may also be seen in conditions like trigeminal neuralgia, posthepatic neuralgia, and migraine. Hyperpathia is an exaggerated nociception. This means pain experience that lasts longer than usual and is more intense and severe than normally expected, and is also often very explosive in character. Hyperpathia is a feature of BMS and many other neurologic and neuralgiform disorders. So, when patients say they have burning oral sensation, what exactly do they mean? Well, burning is often described as a scorching sensation, some using the sun's heat wave as reference and others using chills as reference. Burning of the oral cavity is the main feature of burning mouth syndrome. Paresthesias are a group of abnormal sensations that may be perceived as tingling, as pins and needles, numbness, pricking, itching or pruritus, or formication. Now notice I said formication. This is the feeling of having crawling insects on your body, which in fact is a tactile hallucination that can be a symptom of a variety of conditions such as alcohol withdrawal or diabetes mellitus. Now all these features can be seen in burning mouth syndrome. Paresthesias may also include burning sensations. This brings us to the end of Lesson 1. Take 5 and continue with Lesson 2. Do not forget to mark this lesson as complete.